So I want to start by thanking you all for being here. We are so excited by Migraine Canada to be growing our community. And the fact there are so many people on the line tonight means and reminds us that there are probably 4 million people in Canada living with migraine, close to 500,000 living with chronic migraine. And it just means that people are more aware that migraine exists, and also you are curious about new treatments and want to know more. So I think that's all very good and very positive things. So I thank you for joining us here tonight. So when I give talks to doctors or medical students or insurance companies or employers, I always present a disclosure slide to just remind that I do receive payments to act as a consultant or speaker for different pharmaceutical companies. I also work as a volunteer, of course, for Migraine Canada, but I'm also serving as the current president for the Canadian Headache Society. So if you've never seen me before, I am a neurologist. I am a headache specialist. 100% of my practice is seeing headache patients now. I trained in France maybe 12 years ago and practiced in Montreal and then in Calgary. My passion is to meet people with headaches and migraines and try to make them better. I learn from them. I hope they learn from me. And so this is in a nutshell a bit who I am and why I'm here tonight with you. So tonight's webinar is really about a new family of medications for migraine called Gepants. And you might wonder why I put the picture of an air balloon and a light bulb. It's because those things were once thought to be impossible. Who would have thought that humans could actually go in the air and that we could have electricity? And why I'm putting this out there, it's that the idea of having a scientifically based approach to treat migraine was once a complete fantasy. People thought that migraine was actually just imaginary. There was no understanding of it. And there were a lot of treatments that were not based on anything. And so I think now we are moving forward with science, and that's really a true progress. But then, of course, with more knowledge comes more questions. So we have now tons of questions about every new treatment that comes, may that be a neuromodulation or pills or injections. So tonight we will talk about questions on Gepants. How do they work? How effective are they? Do they have side effects? Will they be covered by insurance companies? When will they arrive in Canada? I want to thank everybody who sent questions in advance. That is extremely helpful for us to prepare talks. And it's just so important to ask questions and then to share and exchange. So in the story of migraine, and if you forget the past ancient history and medieval times and things like trepanations and rose oil and very past treatments, there have been probably now 4 revolutions. The first one was the arrival of what we call triptans for acute treatment, and those arrived in the 90s. And they were really a big breakthrough because before that, like I said, migraine had no chemical cause. It was found to be imaginary. And but then when the triptans arrived, people started wondering, well, if I can treat a migraine attack with a pill that acts on serotonin, well, maybe it's not that imaginary and maybe there's some chemistry and neurology to it. Then in 2011, Botox was approved in Canada for the prevention of chronic migraine. And yes, this is the same toxin that we use for cosmetics, but also for all kinds of other diseases. And so this brought a new aspect on the treatment of chronic migraine. Chronic migraine is having a migraine and a mix of migraines and headaches for more than 15 days per month since more than 3 months. And so people who had never found relief before found relief with Botox. And that also told us that no, these people were not crazy or anxious or depressed. They had severe migraine, and once properly treated, they could get better. And then there's the third revolution, was actually CGRP antibodies, which arrived in Canada in 2018. Up to now, we have now 4 antibodies. So namely Aimovig, Emgality, Ajovy, and Vyepti. And if you would like to know more about these, well, I invite you to watch our other webinar on our YouTube channel, where I present in detail what CGRP antibodies are. And now we have the fourth revolution, Gepants, which are expected hopefully somewhere in 2022 in Canada, but they have been already approved and used in the US for a little while. So I want to say just a few words about CGRP, because this is actually how these Gepants work. So the discovery of CGRP, and what does that mean? So CGRP is calcitonin gene-related peptide. It's a protein that plays a role in migraine, roughly put. This was a major scientific discovery. And to give you an idea on how important that was, the 4 researchers who actually discovered CGRP and its role in migraine were awarded a very prestigious prize last year called the Brain Prize, that comes with a nice 1.1 million pounds of prize for a major discovery. So this is Dr. Peter Goadsby. He is a leader in our field. And why I'm showing this is because, just to tell you, it took 35 years of research since the discovery and the idea that CGRP could maybe play a role in migraine before the arrival of treatments on the market. So science takes a long time sometimes, but it is the way forward. So I want to thank the scientists, the researchers, and also the patients who participated in trials. This is very important. Right, so, the role of CGRP in migraine, I will not go into detail about this, but roughly migraine is an electrical and chemical storm in the head. And we think, and we actually have quite solid proof now, that this pain is caused by inflammation around the meninges, which are kind of the envelopes of the brain, and the arteries, the blood vessels inside the brain. So the meninges and arteries are extremely sensitive. And during a migraine attack, there is an inflammation, so a release of irritant substances that will cause pain, which then you will sense in your eyes, your sinuses, your neck, wherever there are nerves for pain. And so the idea here is that CGRP is part of this kind of inflammatory soup that will cause the pain, and that by blocking CGRP, we can improve migraine. So it makes a lot of sense. When we say blocking, by the way, it means that any protein to do its job, whatever it has to do in our body, usually talks to a target, or we call a receptor. And so if you just want to stop this talk from happening, you will just bind the protein, so either the CGRP, for example, or its receptor with another protein, so to prevent this talk and this action. So this is a bit illustrated here. So the little chunks, and I have a weird kidney form in gray is the CGRP. And then we're showing a sensory nerve fiber, so a sensory nerve that carries pain signals, and another cell that could be a blood vessel cell or a neuron or another sensory fiber. And so CGRP wants to connect with its receptor to tell the receptor transmit pain signals, right, or inflammation signals. And then what happens is, if you put an antibody, for example, so that's the big purple kind of weird shape, clever form, then you can block CGRP or its receptor. And if you use a Gepant, well, Gepants block the receptor of CGRP. This is what they do, okay? They are a family of new drugs. What do triptans do? Triptans block the serotonin, or actually, sorry, they kind of stimulate the receptor for serotonin. So this is a bit of kind of heavy pharmacology, but just to explain to you how much we know about the chemical structure of what is going on in the brain during migraine attack. Okay, those of you who have already heard about CGRP antibodies, and now you're hearing Gepants, CGRP Gepants, right? Probably comes from there. May be wondering, well, we're blocking CGRP, so what's the difference? Well, there are very concrete differences. Antibodies are injectable things, right? So they come in injectors that look a bit like an EpiPen. So people using these inject themselves, usually at home, once a month or every 3 months, depending. There's one antibody that is actually an IV, so it's called Preventives. and it's every 3 months. So they're a bit different, but overall injectables and last for a long time. All antibodies are preventives. They are not used for acute treatment, and they target either CGRP itself or its receptor. Gepants are pills, and they are taken daily, every day. And here's the thing: they can be used as acute treatments and preventive treatments. So they are the first molecules that are used for both aspects of migraine therapy. And then you can maybe see me coming that at some point I will talk about the impact on this on the risk of medication overuse, right? Something that we all know about. So Gepants target the CGRP receptor. So roughly put, those are the differences. So just to kind of illustrate this in a bit more detail, migraine management is always kind of a three-pronged thing. We want to do everything that's around lifestyle adjustments, managing triggers, and then stabilizing the brain with regular habits. We want to treat the attack with acute treatment, and then we want to prevent. This might be basic for some of you, but I just wanted to remind it. And then I put Gepants there in yellow, just to show that Gepants are both acutes and preventives. So that's quite unique. How many Gepants are there, right, in this family? You might know that there are 7 triptans. There are 4 CGRP antibodies. So that's quite a lot of stuff out there. So Gepants, there are 4 of them, 3 of which are currently available in the US. So the names are Gepant, Gepant, atogepant, and Gepant. That's a very funky name. So the brand names are just probably easier to remember: Ubrelvy, Nurtec, Qulipta, and Gepant, to my knowledge, does not have a brand name yet. The companies that market those products are AbbVie and Biohaven. And here's the thing: so they're not all used the same way. Gepant, so Ubrelvy, is only for acute. So in an acute treatment, we want something that works fast, right? So kind of acts very quickly to treat the attack, and does not necessarily have a very long duration in our bodies. As for prevention, we want something that stays in our body ideally for the day, so we can take it once a day, which is easier than twice a day. So Gepant is an acute, Gepant is both, atogepant is a preventive, and then Gepant is an acute. So it's a bit bewildering, but then that's what it is. Okay, so those of you who've been living with migraine for a while probably know this. If you are interested, please listen to our Migraine Talks podcast about acute management. There's one on basic principles and one about severe attacks and advanced concepts. So usually someone with migraine will start somewhere in a pharmacy with over-the-counter analgesics. Either acetaminophen. Many people with migraine use caffeine, which is actually effective unless it is overused or used regularly. Anti-inflammatories are another very good class to treat a migraine attack. And then the famous triptans, which we mentioned earlier. And then if the attacks are tough, then you might combine a triptan and an anti-inflammatory. You might eventually use special forms like nasal sprays or injections or suppositories. And then sometimes with a lot of nausea, you might want to combine something for nausea. So this is and then opioids, anything that's morphine, codeine, Percocet, hydromorphone, Dilaudid, all of these are last resort because they have a very high risk of leading to problems, namely medication overuse, headache, addiction, and risks for health. So that's why we try to stay away from opioids. So what are the problems with those current options that we've had now for probably decades? Well, first, not everybody is improved by these, so they may not work. Some people have side effects, and side effects occur. They occur with anti-inflammatories, with gastric upset, pain in the stomach. They also occur with triptans. Some people do not fare very well with triptans, and I hear this in my clinic every week. People feel drowsy, dizzy, they have chest pressure, nausea, the headache is increased. So triptans can be fantastic for some people, not so good for others. Also, triptans might be contraindicated. Maybe you have a heart problem, or you had a stroke, or you have a lot of vascular problems like diabetes and high blood pressure. And in which case, probably your doctor is going to tell you not to use triptans. Anti-inflammatories cannot be used for people, for example, who have inflammatory bowel problems like Crohn's disease. And then our favorite concept, if you use anti-inflammatories, acetaminophen, triptans, and especially opioids on a regular basis, that may lead to having more and more headache, which we call chronification, getting chronic. So this sometimes bears the name medication overuse headache, which is kind of a science name, but we friendly call it rebound headache. Okay, so let's get started. So I will present a bit of data on the effect of Gepants as acute treatments and then as preventive treatments. Just so you know, a lot of these slides I've presented to actually doctors very recently. So this is all very new in Canada. In the States, it's been going on for a while, but here it is very recent. So are Gepants effective to treat a migraine attack? You know, a motto at Migraine Canada is one size does not fit all, because we know there's so much diversity in migraine for symptoms, triggers, and response to therapy that, you know, you could have a fantastic response to a triptan when your friend is a catastrophe, the triptan doesn't help. The same applies to Gepants. Some people really get well with them and others do not. But if we look at statistics over groups, right? So I'll show you those numbers on the right part. So when we look at an acute treatment for migraine, we look at 4 things, right? We look at 2 hours and then 24 hours, right? What happens on a short period of time and then later. So do you have pain relief? You know, do you get to a mild degree of pain? Are you better? Or are you pain-free, which is even better, of course. So we look at 2 hours for both pain relief and pain-free. And then what happens at 24 hours, pain relief and pain-free. That's pretty sensible. So let's look at the numbers. So let's say you take a Gepant for an attack. Your chance of having pain relief at 2 hours is 40%, 40 to 50%. And your chance of still having pain relief at 24 hours, 35%. So some people recur. I mean, the pain comes back. We all know this. And then the risk or the chance of being pain-free, which is what we want, is 20%. And then it's not 23 hours, 24, 15% are still pain-free. So it's not magical. It's not a cure, but definitely for some people, it does work. And then I'm kind of sorry for this very complicated draft, but I just wanted to give you a bit of a ballpark. And the key message is here, right? You see all these bars and it's probably a bit confusing, but on the left side, you see triptans, and on the right side, you see Gepants. And the idea in blue, you have, you know, the 2-hour pain relief being somewhat better at 2 hours. You can see the blue bars arrive around 50 to 60%, right? But then if you look at the yellow bars, which are, you know, sustained pain-free, or the orange bars, which is sustained pain relief, like being better really longer or later, we can see that triptans seem to be a little bit higher, a little bit better. So this actually correlates to what I hear from my US colleagues, and they say that Gepants do not seem to be quite as effective as triptans. But once again, it varies depending. But if you look at a group of people, the chance of having a great success with a triptan is probably a bit higher. Nevertheless, some people do not respond to triptans or have side effects, or like I mentioned, so very good options with effectiveness. Side effects, what could happen? Well, nausea, somnolence, and dry mouth were the key side effects. And if you compare the placebo, because even people who take a placebo can actually have side effects. Well, we call that the nocebo response. So atogepant here, 50 milligram and 100 milligram, you can see that nausea, you know, so there's actually, it's interesting here to see that the higher dose of atogepant seems to have a bit more side effects. No surprise there. So let's say you take the higher dose of atogepant, you will have maybe 4% risk of nausea, 2.5% risk of being somnolent, and 2.1 risk of dry mouth. And it is higher than if you take a placebo. Some, you know, I just wanted to mention in the studies, there were no serious adverse events. So something that a risk of harm to the body, no death, that's good. And but more importantly, there were no adverse events that led to someone deciding not to take the drug again. So it means that these drugs seem to be very well tolerated. And then I showed you, that the results for effectiveness and saying, okay, maybe they don't work as well as triptans, but this is hot from the press, from the international conference we had virtually recently. And it just confirms something we know. It's that if you treat a migraine attack, treating early is the good way to go. The more you wait, the less chance of success you have. We know this. So this was shown for triptans, we know for NSAIDs, and for Gepants, it's the same story. So let's look at the table here. So 2-hour pain-free, getting completely free at 2 hours post taking the dose. If you treat when the pain is mild, you have 55% of chance of being pain-free. That's actually almost double the chance if you wait to have or if the pain is already moderate to severe. For example, you wake up with it, right? And then return to normal function. That's an important thing. Being able to just go back to whatever your plans are for the day. 60% if you treat when mild, 42% if you treat when moderate or severe. So that's a very important concept in acute treatment, and it does apply to Gepants. Then a lot of you have a lot of attacks, and then you are told by your doctor probably, well, if you have more than 10 days per month of migraine, you cannot treat early all the time, because then you will kind of have rebound headaches or medication overuse. So this overuse catch-22 is really a plague if you have frequent headaches. Up to 50% of people who have chronic migraine will kind of have this overuse tag on them because they fit those criteria, which is namely taking something more than 10 days per month. And then more headaches leads to more medications, and you get caught in this kind of vicious cycle of medication overuse and chronic migraine. So the idea here, and that's where it's interesting to remember that Gepants are both acutes and preventives, is that in theory, if you use a Gepant on a repeated basis, well, it might become like a bit of a preventive. So the idea is that Gepants are not supposed to cause medication overuse headache. Now, I want to be cautious because there's no absolute proof of this. But we have some data in the rats, the rats and the mice. We use them for research a lot. So there are models where we look at mice and rats and we check by giving them pills or drugs, do they develop something that looks like medication overuse? Do they become hypersensitive to pain? And if you give a rat a triptan or opioids, we know they are more sensitive to pain by different techniques. And this does not happen if you give a rat a Gepant. So it seems to be quite encouraging. And so the idea is that, there would not be medication overuse, so no restrictions in theory to use Gepants on a regular basis, as they could kind of get close to being preventives. Okay, so now talking about prevention, just a segue to this next section. Are Gepants effective to prevent migraine? So I won't dig deep into that, but just to remind you, when we study prevention drugs, well, we'll look at a bunch of things, but one of these things is the decrease in headache days per month. So example, someone who has 8 days per month at the beginning and has a 50% response will go back from 8 or go down to 4 days per month, right? Not a cure, no zero, but still much improved. Someone who's a 75% responder, or sometimes we call this a super responder, will actually go down by 6 days, so down to 2 days per month. And now with CGRP antibodies, we even have actually 100% responders. If you start higher, let's say you are on the edge of chronic, you have like 12 to 14 days per month of headache, of migraine attacks. Well, if you're a 50% responder, you'll get down to 7 days per month. And if you're a super responder, you'll get down to maybe maybe 4 to 5 days per month. So frequency is one thing, but then I hear a lot from my patients in my office about other things. My triggers are not a problem anymore. the attack is less intense. I'll have less migraine symptoms like sensitivity to light or sounds. I can treat easily. Like if I take a triptan, let's say it works now, I can plan my activities. So that's the idea. Those are the things we look at in studies. Okay. So what do we, just to give you a ballpark estimate, if you take oral stuff, you know, tricyclics, amitriptyline, Elavil, Inderal, topiramate, all those drugs that can stabilize the brain and be a good preventive for migraine. Well, oral preventives for migraine, the ballpark response for a 50% improvement are 40%, right? So those are the numbers here. And you can see the orange and blue and green bar. Those are the results from the studies. So overall, you try preventive, you have 4 chances on 10 to get better 50% or more, right? So those were the studies on the orals. If you'd like to know more about prevention of migraine, basics, how to try stuff, please listen to our podcast on Migraine Talks. Okay, so let's look at the numbers for the 50% response rates for CGRP antibodies and atogepant. So you can see that it's closer to 50 or 60%. So the effectiveness of those drugs blocking CGRP seems to be better than the oral preventives. But I mean, we cannot compare apple and oranges, but just to give you a little bit of ballpark. So does everybody respond? No. Is this a miracle or a cure? No. But can it change someone's life if you're a good responder? Absolutely. Right, side effects again. So what are the key side effects of atogepants in the studies? And remember, studies are not real life. Those are people who participate to a clinical trial, and they might be a bit healthier than the usual population. Fatigue, nausea, and constipation, right? Those were the side effects that were seen, especially at higher doses. And some side effects were noted about 2 to 3% compared to the placebo. So once again, a good tolerability, and there was no, a lot of us are always concerned by the liver, are the drugs impacting our liver, and the Gepants are metabolized in the liver. There were no liver abnormalities above the placebo rate found. Then a lot of you might have chronic migraine and might ask me, what about chronic migraine results? What I've showed you was only for episodic migraine. Well, stay tuned because we don't have the results yet. Of course, there will be studies, but they're not out yet. So hopefully the results will look like the results we get with CGRP antibodies as well, which is probably 40% of a 50% response and 20% of super response. I apologize for all the percents and percents. It's just the way that we scientific people, we describe results. We don't like to say it works or it doesn't work. Like we like percent. All right, so here now are questions that were sent to us by people who contacted us. So what about using Gepants long-term? So on average, so first one question, on average, how long does it take to experience a benefit? So on average, in these studies, the benefit was seen after 3 months, but in some people, the benefit shows even after 1 or 2 weeks. So once again, there's diversity. Some people get better super quick, and others, it takes longer. And as an example, with CGRP antibodies, for people who are chronic and in a deep state of chronic, sometimes we wait 6 months just to make sure, because some people just like consistently improve and improve and improve, and then they reach a good response after a few more months. But I would say if you have episodic migraine, let's say you have 8, 10, 12 days per month, and you try a Gepant, after probably 1 to 2 to 3 months, you should have a good idea of your response. Okay, another question. With long-term use, will the medication become less effective? Sometimes we call that wear off, or in medical Latin, tachyphylaxis, to sound fancy. We don't know. And we don't know because those drugs have not been on the market, atogepant and rimegepant for prevention. They've not been out there enough, so we know this. In the studies about CGRP antibodies, we thought there was no wearing off on the long term. But then in real life, it looks that some people, they get better initially, and then after 8 months or a year, they have a wear off. They're not as good as they were. Why is that? We don't know. So we'll need to study this and look at the facts. Can we take them on long term, all our life? This is a question all my patients ask me. They say, am I going to take this all my life? So I usually tell people to think maybe shorter term, a year, 2 years, 3 years, and then we reevaluate how are things. So once again, we don't know. If as a scientist, I cannot answer this question. I mean, we hope yes, but then we will see how it goes after years and years. Very, very probably, because they are so well tolerated and there's no red flags so far, probably they can be used on the long term. And so that's what we hope for. Will it cause irreversible side effects? So far, we don't see any irreversible side effects. So that's very reassuring. Medicine is medicine. Human bodies are human bodies. Of course, when there's a new drug around, we always keep a close eye. What's going on? Are there any unexpected things? So there will be a close watch on security like we do with any new treatment. But so far, these drugs seem to be pretty well tolerated and quite safe. Okay, can we use Gepants with other medications? Can patients take Gepants with triptans? Yes, because triptans were actually used during the studies on prevention. So patients could use their triptans, so no contraindication there. Anti-inflammatories, same thing. People in studies could use their anti-inflammatories, no problem. Botox is easy because Botox can be combined with pretty any pill. So that's a nice aspect of Botox. It's a local thing, does not interact with pills. And then the question is, what about combining a Gepant with a CGRP antibody? They act on the same thing, CGRP or its receptor. So are they going to is it useful? Could there be a risk? So far, I can tell you in the States, a lot of people do combine them. So far, it seems okay. But is it effective? I think we need more observation to learn that. But I'll give you a bit of a piece of something that's discussed among specialists. This is kind of a high-level data. Some people who use antibodies at the end of the month, they will have a wear off. So they say their last week is tough. Like it's like the antibody is kind of disappearing and then the migraines creep back up. And so in this wear off, in the studies, it wasn't clear, but in real life, we see it 20 to 34%, 35% have it or report it at least. And so could we, and this is just something that experts talk about, no research, I'm not recommending it. Would it be possible to say, well, the antibody works for 3 weeks and then we can patch with like a Gepant for a week? No official report on that. But I'm just telling you how, we're just put in those situations where we have to think and we have to observe and ask ourselves questions and find the answers and make sure that we're just progressing based on facts. More questions. Are there patient Gepant trial happening in Canada now? If so, is there a possibility of new patients participating in the trials? This is such a great question. And, it's so great that people want to participate in research. Now, if you want to find a research, you can go on clinicaltrials.gov. This is a public free website. It's very official. And then you can actually just do a search and say, I want a study on migraine, a Gepant in Canada, and you say search. At present time, I didn't find any study ongoing. And then another question was, could the Gepants be a treatment for vestibular migraine? I have a specialized clinic with an ENT, so I see tons of vestibular migraine. I know how disabling this is. I really hope. I saw my first case today of a patient who really got better with a CGRP antibody and had vestibular migraine, and both the headache and the vestibular symptoms got better. But then I went to PubMed, which is our kind of favorite place for doctors to look for data. And vestibular migraine Gepant retrieved no results. So far, there's nothing published on it, but of course it is on our radar. So when are Gepants coming to Canada? We don't have a date. Believe me, we asked AbbVie, which is the company that is marketing Gepant and atogepant, and I suspect some of them might be listening tonight. We're just asking them on a repeated basis when. So as soon as we know, we will let you know. So we don't have a date now, but it should be in 2022. Now, the question of cost, how much will the Gepants cost, and will they be covered by my public or private drug plan? Money, 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 very legitimate question. In the US, Ubrelvy is $100 for one pill, right? So if you Google this, you can find it on different kind of online buying places at $85 for one pill. That's costly, A triptan will be 10, 15 bucks per pill or even less, depending on your pharmacy. So we are waiting to know, what cost will be proposed for Canada, because we know Canada is different than the US. The system is different. Pharma companies are not regulated the same way. We don't deal things the same way. So hopefully the cost will be lower, because as you know, private insurance and public insurance people look at cost effectiveness. What do you get for your buck, right? So if my taxes pay for this drug, what is the outcome? What am I paying for? And so they are looking with very, very fancy studies and analysis and statistics, and I hate statistics personally, but they are very useful. Is the cost justified by the results, by the outcomes of any treatment? They look at like all chemotherapy, medications, seizure drugs, any drug is evaluated by CADIF, which is a Canadian agency for assessment. Health Canada, of course, looks at the safety of the drug and the effectiveness. And then CADIF looks at its kind of cost effectiveness. And then PCPA, which is the Pan-Canadian Pharmaceutical Alliance, negotiates the cost of drugs. So it's a process that takes years. And so the criteria, right, that might actually be used to say, yes, you can have this drug or not, we'll pay for it or not, will depend on the price and will depend on, just also results from research. So let's say they could say, I'm just making this up, okay? Okay, you can have a Gepant if you have episodic migraine and you have, let's say, 8 days per month or more, and you have tried and failed or not tolerated 2 or 3 oral preventives. Those are very close to the criteria of the CGRP antibodies. For Gepant, for example, well, maybe they will say you have to fail or cannot take triptans, and how many triptans you must try, I don't know. So all of this is in the air. We don't know yet, all right? But if the cost is high, very likely there will be criteria and forms to fill and all that stuff. And so that's where I strongly encourage everybody with migraine, and of course my patients, we do this together, to have a headache diary. It can be a paper, it can be Migraine Buddy, but a favorite in Canada is the Canadian Migraine Tracker. Very simple. It's not very fancy, like it's simple, but it can help you have results and fill certain questionnaires. So you can have those numbers to give to your doctors, so the insurance company can know how you are doing with numbers and not only impressions. And finally, before we break for questions, what will Migraine Canada do to help people access Gepants, right? Well, we want to work, we want to help, right? We want people to access treatments, whatever they are. So we participate to these CADIF submissions based on your insights. We advocate to PCPA to emphasize the importance of access. And believe me, if there was no patient association, it would send a very poor message. So it's great that we are there to bring your voice. We discuss with health ministries to support the reimbursement of treatments by drug plans. So we push on the health ministries to say that migraine matters. We interact with private payers and employers to raise awareness. I just gave a talk to Benefits Canada, French and English last week, which was very well received on the impact of migraine in the workplace. So those are all conversations that we keep going. It takes time, but I think this is very important work. And I want to thank a huge thanks to Wendy and Randa and all the Migraine Canada board and all our volunteers who make this possible. So thanks for that. I encourage you to look at our resources, podcasts, PDFs, to go on our advocacy page, to investigate the migraine tree, which is a great resource, to watch our webinars, and invite people, talk about migraine, tell the people so we can grow our community. So as an ending, there's nothing, never say there's nothing else to do, because at present times, there's really a lot of options for you out there. Maybe you've tried a lot of these already, but there are a lot of things to do. And Gepants will be added to the migraine tree, actually in the acute treatment section and the preventive treatment section. So the idea now is, with new treatments, well, we can reverse the vicious cycles of migraine, decrease the stigma, encourage people to treat migraine, have more researchers do research, have more doctors treating it, and just breaking all those, like bad things from the past about migraine, give it an image of hope, empower patients, which we are doing tonight, and have better outcomes, happy people living their lives. So I thank you, and I'll take questions now. So Randa, should I
all right,
sharing?
Yeah, we can do that.
Unless because I don't think I'm going to go back to the slides. So
okay, if you think you will not, let's just stop sharing and I'll start. Thank you so much for this really, really important presentation, very timely, and I think you covered so many areas, and that's really, really valuable for everybody. We have a few questions. We have time for a few questions, so I'm going to start. So the first question is, I suffered from continuous